Hi, my presentation is on cognitive therapy and the effects on eating disorders by Savannah Woolen. So the overview of my topic is cognitive behavioral therapy is an evidence-based therapeutic approach. It focuses on challenging the negative behaviors and thoughts patterns to improve mental health outcomes. Cognitive behavioral therapy is a psyche-therapeutic approach that involves a variety of techniques. It creates an understanding between their thoughts, feelings, and behavior. It also helps create strategies for good behaviors. Cognitive behavioral therapy is successful in emotional regulation by involving the modulation of brain's emotional processing system. It was created in the 1950s by a psychiatric Aaron Beck, who emphasizes the role of thoughts, feelings, and behaviors. Eating disorders are illnesses in which people experience extreme disturbance in their eating behaviors. Some common disorders are anorexia, bulimia, and binge eating. Eating disorders are more common than you may think. They can affect anyone, regardless of age, race, or gender. Some symptoms include avoiding certain food groups, restricting calories, overeating, and extreme exercise. I chose this topic because I've always been interested in eating disorders and how the psychological factors can explain why people have eating disorders. And also, someone in my family has struggled with an eating disorder before, and I thought that the cognitive behavioral therapy was really interesting. Theoretical background. Key theories. Cognitive behavioral theory, Fairbairn's transdiagnostic model, and cognitive interpersonal model. To start with the cognitive behavioral theory, their core idea was if you change the thoughts, you can change the behavior within therapy. They believe that eating disorders are maintained by distorted thoughts, and when you change the thoughts, the behavior of the eating disorder changes. Next is Fairbairn's transdiagnostic model. That study says that all eating disorders share the same problem, which is overvaluation of weight, shape, and eating, and this leads to a cycle. And cognitive behavioral therapy targets all the factors of the cycle, and that explains why it works for so many disorders. Next is cognitive interpersonal model. Cognitive interpersonal model shows how family and interpersonal responses to cognitive behavioral therapy. It focuses on cognitive thinking and social factors of the eating disorder and how we can change those to recover. Next is foundational studies, and I researched a study by Fairbairns and Argus called the Trans-Diagnostic View of Eating Disorders. Fairbairn helped propose that all eating disorders are more similar than different from each other. This became the same process to maintain all eating disorders led by the development of cognitive behavioral therapy. So next is cognitive mechanisms, which is the brain regions and cognitive processes involved. First is the amygdala. The amygdala acts like the brain's alarm system, and it processes threat stimuli and triggering body's fight or flight response. The amygdala is often hyperactive in individuals with disorders, but it has showed reduced activity following cognitive behavioral therapy. Next is the prefrontal cortex. The prefrontal cortex, it helps regulate the amygdala by analyzing situations and deciding if it's a threat or not. The prefrontal cortex becomes more active and efficient after cognitive behavioral therapy due to the increased activity helping inhibit the hyperactive limbic system, which keeps emotions in check. Next is cognitive behavioral therapy enhances emotional regulation. The limbic system, amygdala, and hippocampus play a central role in processing emotions like fear, anxiety, and stress. Cognitive behavioral therapy regulates these emotions by changing the way the brain responds to negative emotional stimuli. and this leads to improved emotional regulation. Lastly, neuroplasticity plays a crucial role by promoting the creation of healthy neural pathways that replace the unwanted and unhealthy behaviors. And this diagram by Yuan, I put the site right there. In the blue areas on the diagram, it shows decreased activations in patients after going through cognitive behavioral therapy. Next, I'll be talking about cognitive mechanisms and how they relate to my topic. So first is perception. And my example was people with eating disorders have a distorted perception of body size rather than someone else. Example, someone may look into the mirror and see themselves bigger even though their body is not changed. It's called body dysmorphia. You look in the mirror and you see something way bigger than your body actually is. Next is attention. My example was selected attention to the body-related cues. A person may walk into a room and only notice food, thin people, or mirrors. Even in a busy environment, their attention is still pulled towards their eating disorder thoughts. Next is encoding. I said encoding negative comments about their weight. Encoding is the process of converting experience into memory so they can be stored long term. So if someone says a mean comment about someone's body or weight, they're going to keep that comment in the back of their mind and constantly replay it. So next, I'll be talking about current research. The first article that I read was Neural Effects of Cognitive Behavioral Therapy in Psychiatric Disorders. So the purpose of the study was that researchers wanted to understand cognitive behavioral therapy and how it changes the brain. They reviewed many studies showing brain regions constantly changing. So they conducted a systematic review of studies using the brain image before and after. They also used the activation likelihood estimation, which is a statistical method. Some of their key findings was that cognitive behavioral therapy led to consistent changes in several areas of the brain involving stress, emotion regulation, and thinking. The conclusion of this study is that cognitive behavioral therapy is biologically effective treatment across all psychiatric conditions. This study highlighted many of the same regions involved in eating disorders. The second article that I read was Absolute and Relative Outcomes of Cognitive Behavioral Therapy for Eating Disorders in Adults. So the purpose of the study was to see how effective cognitive behavioral therapy is for treating disorders in adults. Some of the key findings was that 36 randomized trials of cognitive behavioral therapy showed a large treatment effect compared to controlled conditions. Also, 36% of adults receiving cognitive behavioral therapy, their behaviors and thoughts were fully diminished. And they also found that cognitive behavioral therapy was the most effective at treating bulimia and binge eating. The results for anorexia was not conclusive and limited. They also found that there's a need for enhancement or better treatment because some people are found to never fully recover and anorexia is conclusive and limited. Lastly, I read about the predictors of dropout outcome and release in web-based guided self-help cognitive behavioral therapy among patients with eating disorders. So the purpose of this study was to identify who is more likely to drop out of cognitive behavioral therapy and who responds best to treatment and who is at risk for relapse. So they found that data from 190 adults undergoing online guided self-help. The majority were female and around 39 years old. Predictors were examined using demographic data, symptom severity, and mental health issues. Some key findings were that people were more likely to drop out if they were male or lower educated. Treatment outcome was that people with more psychological difficulties may improve more slowly, but can still benefit long term. There is also no baseline factors predicted relapse after treatment. The conclusion of the study was that dropout was more common in certain demographic groups, and those with more comorbid conditions may need additional support early in treatment. So impairments and disorders. So with an eating disorder in general, there is anorexia nervosa, which is just overvaluating your body and restrictive eating, and also bulimia nervosa, which is binging and then vomiting or using laxatives afterward. Next is binge eating disorder, which is just reoccurring binging episodes without compensatory behaviors. And these can also come with depression, anxiety, and obsessive compulsive disorder. They usually tend to work together. So next is interventions with cognitive behavioral therapy affecting eating disorders. The first article I read was Do We Need to Challenge Thoughts in Cognitive Behavioral Therapy by Longmore and Worrell. Longmore and Worrell questioned a core consumption in traditional cognitive behavioral therapy. Is challenging thoughts necessary for therapeutic change? They found that many people show rapid system improvement early in treatment before specific cognitive interventions start. There's also limited evidence that changes in cognition cause symptom improvement. They also suggest other processes in cognitive behavioral therapy like behavioral experiments, exposure, or changing behavior. And therapists may not always need to focus on changing cognitive content in a strictly rational way. This article challenges the assumption that changing distorted thoughts must be done through direct logical challenge. My next article that I read was Development and Usability Testing of an Online Platform for Provider Training and Implementation of Cognitive Behavioral Therapy Self-Guided Eating Disorders. So the purpose of this article was to develop and test an online platform to train providers in cognitive behavioral therapy, guided self-help for eating disorders. They wanted to support implementation of cognitive behavioral therapy with patients. So the method was user-centered design with two different cycles. Cycle 1, the providers and patients tested separately. And then cycle 2, provider patients tested platform over 3 weeks. The conclusion of the study was that the platform is feasible in training providers and supporting cognitive behavioral therapy delivery. The conclusion is the platform is feasible in training providers and supporting cognitive behavioral therapy. Some suggestive improvements was the technical functionality. My last intervention that I read about was the efficiency of individual cognitive behavioral therapy for eating disorders. So this meta-analysis examined 42 randomized controlled trials to evaluate how effective individual therapist-led cognitive behavioral therapy is for various eating disorders. Cognitive behavioral therapy was found to be significantly more effective than waitlist non-treatment control groups. However, compared to active treatments like other psychotherapies, cognitive behavioral therapy did not constantly show superiority. This can indicate that other therapeutic approaches may be effective. Lastly, I researched a case study titled Using Controlled Cognitive Behavioral Therapy E and the Treatment of Anorexia Nervosa with Comorbid Obsessive Compulsive Personality Disorder and Clinic Perfectionism. So there was a girl with anorexia nervosa and obsessive compulsive personality disorder, and she was treated with enhanced cognitive behavioral therapy electronically combined with cognitive behavioral therapy for perfectionism. So there was 40 sessions of cognitive behavioral therapy tailored to involve parents, build motivation, and address perfectionism. And this was targeted by over-evaluation. Over the treatment of a year, her eating disorder symptoms decreased significantly. Her perfectionist traits improved, she learned to set boundaries, and balance achievements and rest. So by the end of the therapy, she no longer met the criteria for anorexia nervosa or OCPD. So in conclusion, cognitive behavioral therapy is the most effective treatments for eating disorders. And research shows that cognitive behavioral therapy helps patients change unhelpful thoughts, regulate emotion, and reduce bad behavior. Cognitive behavioral therapy offers self-guided help that can be accessible online, and individual differences can affect treatment response, but there's an importance of personalized cognitive behavioral therapy approaches. And lastly, these are my references.